I've actually decided not to talk because it's impossible to follow that, isn't it? That's ridiculous. Can we just give Scott and Cliff a big hand because... I mean, that's just seriously inspirational. You'll notice that, I actually chose the topics and dished them out for this session. You'll notice that I didn't dish the inspirational one out to me. And I've completely forgotten what I was going to say next. So let's move on. Now, I thought I'd demonstrate initially what metacognition is. So thinking about thinking. So this is what I'm thinking right now, which is what sort of a jackass puts himself on stage with these guys to give a talk. You know, we've got Scott Weingart, the Justin Bieber of emergency medicine critical care. Cliff Reed, the cross-dressing Dustin Hoffman of resuscitation. And as we're about to find out, Simon Carley, the Leonard Nimoy of evidence-based decision-making. But I can console myself with the knowledge that they too are all jackasses. And I put it to you that you're all jackasses as well. It's not just the doctors. If you're a nurse, if you're a student, if you're a paramedic, if you're a lawyer who liked the title of my talk and thought you'd come in and check it out, you're a jackass as well. So let me explain. I had a teacher in medical school who... Anyone else from Auckland here? There's a forensic pathologist in Auckland called Tim Kohlmeyer. And anyone who's met him will remember him. One of his catchphrases is, all doctors are jackasses. And what he means by this, it's meant to be a guard against inheriting the thinking of others. He wants us to sum up any situation for ourselves. He wants us to make up our own mind. Trust no one. But I would extend that further because you can't trust yourself either. You might be sitting there thinking you're immune to these cognitive biases, or at least they don't affect you as much as everybody else. And you're not alone, because when they study this, across all cultures, from the Himalaya to the Serengeti, everybody thinks that cognitive biases affects others more than they do themselves. But we're all wrong. And this blind sight bias is just one of the hidden traps that's out to get us. This talk is about how we think, how we make decisions in critical situations. It's about how we get it wrong, and hopefully it's a little bit how we can get it right, how we can make it better. So let's start by talking about how we think. And the current best explanation for this is what's called the dual process model. You've got 3 seconds to write this down. Okay. It looks complicated, but it's not. There's just 2 systems involved. System 1 is that intuitive, that gut feeling that we get, that initial summing up of the situation that happens automatically. We can't turn it off. System 2 is when we have to step back, when we think analytically. It's slower, it's more deliberate. We can improve it with learning and education. So when we see a patient, this is kind of what happens. The patient's in front of us, and we have this innate pattern processor that checks to see if it fits a known pattern, or what some people call an illness script. If it's recognized, then system 1 can run riot, just automatically, and it just ticks things off effortlessly. If not, then we have to do some work. We've got to engage system 2 and start thinking hard. You can think of system 1 like Captain Kirk. He's our inner Captain Kirk. You know, he likes to shoot from the hip. He has no understanding of reason, probability. He's affected by emotion, by the ambient conditions. Context is everything. Most of the time, like in familiar situations, it works well. He'll get it right. But if it's a complex or novel situation, he might come up with the right answer, but it might be to the wrong question because he'll try to simplify things. System 2, no surprises there. That's our inner Spock. He's much more logical. It's analytical. It's stepping back, but it requires a lot of effort. It's much harder to operate in System 2. It's much harder to be Spock. We think that we're Spock, but we're not. Most of the time, we're just Kirk running around being an idiot. This can be improved. How we operate in System 2 can be improved by education, by being intelligent helps, but it's not the whole answer, because rationality and intelligence are not the same thing. In the same way that to solve a calculus problem, you need to study mathematics, to be logical, to be able to reason, we need to learn about critical thinking. We need to know about logical fallacies. What's important is how System 1 and System 2, how Kirk and how Spock interact, and they can do so in a number of ways. Now, Pat Crosscarry describes the human mind as a cognitive miser. What that means is that basically we're lazy. We don't like to exert effort unless we have to, and that's why we like to operate in Kirk mode in System 1. It takes effort. It's hard work to operate in System 2. However, if we repeat processes in System 2, if we do them over and over, we can relegate them to that System 1 level. This is what happens when we learn a procedure, whether that be learning to drive a car, whether it be learning to put in a central line. What once required conscious effort can become unconscious and almost effortless. And then System 1 and System 2 can also override one another. Usually when System 2 overrides System 1, that's a good thing. When Spock overrides Kirk, it's a good thing. So for instance, a classic example is the patient who comes in with loin pain and hematuria. Kirk is shouting out, renal colic, renal colic, renal colic. But Spock is saying, he recognizes there's a cognitive checkpoint here and says, whoa, hang on a sec, dude. Stand back. How old is this patient? Do we need to rule out a AAA? More problematic generally is when System 1, when Kirk overrides System 2, Spock. Now, this can happen just because you're a jackass. You may not be as rational as other people. But no matter how intelligent or rational you are, there are certain situations, like Cliff said, we're affected by the environment, we're affected by what's going on around us when this happens. It's when we experience cognitive overload. When we've got 20 patients waiting, it's only natural to want to work faster, use less effort, just trust our gut. And our gut can be right in most situations, but there's not every situation, and that's why System 1 can run into trouble. What an expert clinician does, so I've been told, I wouldn't know, is that they can learn to toggle between these two modes. They use Spock to control Kirk. So Kirk is throwing up all these intuitions all the time, but Spock is saying, don't jump in, stand back, think of other possibilities. And through that way, and learning to alternate between the two, work with the two together, that's how we make good decisions. Now, so in a nutshell, we've kind of got a system for how we make decisions. What we're going to do now is take it to our workplace and see how this pans out. Now, we'll start in the emergency department with a case, and in this case, of course, any resemblance to real individuals is purely coincidental. So we've got a patient here. His name is Scott Carly Reed. And he's a 50-year-old man who's come in at the start of the night shift, having apparently had a fall whilst going to the toilet, and he's come in with a sore foot. Triage nurse sends him over to fast track. It's a typically busy night. There's a long wait. He's starting to get a little bit upset about this. Goes up to the triage desk, reminds them about the out-of-court settlement he got from the hospital last year for the botched operation on his neck that he went through. And then also sort of says, and what about my chest pain? So sure enough, the night ED reg is sent in there, quick, smart, to try and sort out the situation. It's totally unrealistic, isn't it? So he's confronted by this patient who's already starting to get a bit upset and irritated. He starts to get a little bit more history about what's gone on, finds out he's had a recent overseas flight, that he's got a brother who's got a DVT, that he's got chronic neck pain, obviously, that he's a diet-controlled diabetic, that he's a smoker, he doesn't like bright lights, and he doesn't like his feet getting cold, and he's very, very hungry. So he chucks him a sandwich and then quickly orders an X-ray of his foot, orders a D-dimer, because he's either well score 0 or 3, one of the two, and then sends him over to the majors area and then has to run off to the resus room to see the next code. And sure enough, it's handover in no time, and it's a busy heaving department, but the emergency consultant coming on knows that handover is a critical period. He makes sure that he gets a good detailed handover of everything. He seizes a few red flags in this case and says, PE is a possibility, but could it be MI? So knowing this, he goes in to see the patient as soon as possible. And he's confronted by this scenario. Our patient's having an argument with the nurse because he didn't want cheese in his sandwich. And he's getting quite irate and he's going to make a complaint. So our emergency consultant starts, getting in there, trying to ease the situation, calm things down. And then you didn't do this photo very well, Cliff. And then the patient starts to look distressed. He starts complaining of chest pain. So they get an ECG quick smart. Hopefully you can see that. I put circles around the important bits. He's having a big anterior MI. He gets rushed off to the cath lab and they find a serious culprit LAD lesion, but he's also got multi-vessel disease, and in the end ends up getting a bypass operation and gets sent off up to the guys in ICU. The operation, everything all goes well. But over the next 2 days, he still remains intubated and he's got increasing oxygen requirements. The ICU registrar checks out his X-ray and is worried about this opacity on the left side. Maybe there's an effusion there. Maybe they should drain that. Gets their boss to check it out. Their boss is a little bit more concerned about the pneumothorax on the other side, having maybe got bigger as the patient's starting to deteriorate. So that's a snapshot of a case. What I'm going to do now is get the scalpel out and try and chop this apart as part of sort of a cognitive autopsy, because we've got the events laid out that seem straightforward, but there's often a lot more that's going on. If you had to guess, who tends to make the most mistakes, Kirk or Spock? It's Kirk. He's the one who's subject to all these cognitive biases, all these sort of almost heuristic ways of going about things. And we have them because a lot of the time they work. In familiar situations, in simple situations, they get us by because they're effortless and they've been presumably developed through evolution. But in novel and complex situations, we can run into big trouble because of these cognitive biases. Now, there's a lot of them. I'm going to break them down into 6 categories, or what I almost think of as walls or barriers to clear thinking. And the first one is over-attachment to a particular diagnosis. So in some examples of this, at the triage desk, that triage nurse would have, it's totally understandable. This guy comes in, he's fallen over going to the toilet, he's got a sore foot. They're going to anchor on it being a mechanical fall and he's got a sore foot. It's busy. You haven't got time to talk to the guy wearing sunglasses in the emergency department. And then they're subject to the confirmation bias because they've already kind of got this idea of what's going on. If they do explore further, there's a tendency for us all to focus in on the things that support the conclusion we're already coming to and ignore the minor details like a little bit of chest pain that goes against what we already think. And similar things were happening when the ED doctor saw the patient. They latched onto PE and that led to them kind of overlooking the possibility of either other diagnoses. However, when the emergency consultant came on at handover, having probably seen all these errors before, having realized that the diagnosis had not been fully verified yet, he was able to avoid this error of premature closure. The second wall, the second barrier, is failure to consider alternative diagnoses. If we go to what happened in the ICU when they looked at their chest X-ray, we all do it. You see the abnormality. There's an effusion, an opacity on the left side, and then you stop. It's called search satisficing. We do it when we look at neck x-rays. What's the most commonly missed fracture? The second fracture. It's important to be systematic, but it's hard to do when you're in a rush or you've already found something that needs to be acted upon. Related to this is a thing called Sutton slip. Everyone know who Sutton is? He's the bank robber who, when asked why he robbed banks, said, because that's where the money is. Sutton slip is jumping in on the obvious. Sometimes we need to look past the obvious. The third wall, the third barrier, is inheriting someone else's thinking. All doctors are jackasses, remember it. We're subject to this thing called diagnostic momentum. Every time there's a transition of care, labels become stickier and stickier. And there's also the framing effect. This particular case, I can present it to you as a chap a bit of a difficult patient who fell over going to the toilet. He's got a sore foot. He got a bit annoyed with waiting, went up and came up, started complaining of chest pain. Or I can present this as a patient with chest pain in the context of a collapse complicated by a foot injury. Those two stories describe exactly what happened, but they lead you down totally different paths. There's 6 walls, by the way, if you're thinking this is going to go on forever. I have got 4 hours there, haven't I? Yeah. Okay. The 4th wall is errors related to prevalence perception or estimation. There's this thing called the availability bias. What if I told you that emergency registrar in the ED 2 weeks before had missed a PE? It's going to be at the forefront of his mind, isn't it? The things that we think about most easily, the things that come to mind most easily, are the things that we think are most likely. And this also contributes to what's called base rate neglect. Because of this, he forgot that a man who's 50 is a smoker, is a diabetic, is probably quite likely to be at risk of ischemic heart disease. And the 5th thing, patient characteristics or presentation context. Looking at this guy, tinted speculopathy, soft collar on, fluffy slippers on, I mean, that's going to affect, that's just setting him up for negative stereotyping, isn't it? You just want to get that guy the hell out of your department as soon as possible. And then there's this thing called triage queuing. And actually, in this case, the emergency registrar did well to overcome this. The patient was sent to the fast track area. If you see the same patient in the majors area and in the minors area, the exact same patient, the same presentation, you will treat them differently. You will see them differently. And finally, there's physician affect, physician personality and decision style that can also lead to errors. This is a junior registrar who just recently missed a PE. What if I also told you that he recently moved into state? He's on his 4th night shift, 12 hours in a row. He's working there by himself. He's just moved into an apartment where there's a noisy building site next door, and all his spare time is spent studying for his Part 1 exams. When you add it all up together, we've got a bloody hard job. And when you see this patient in front of you, who perhaps isn't the most likable guy, we're all going to be subject to visceral bias. These pitfalls in thinking would be bad enough if you don't then put it in our situation. You'd have to be a jackass to do our job. I mean, it's insane the demands that we have. We have an incredibly high density of decision-making that we have to do. We have to deal with incredible degrees of uncertainty. We have no control of our workload, what's coming in, what's going out. We often, our peak hours are after hours when we're fatigued, when often there's junior staff around, when our circadian rhythms are disrupted. We have to deal with multiple patients, multiple problems, all competing, constant interruptions. It really is. I'd rather be running the NASA program sometimes. When you're in the emergency department and all hell breaks loose. Pat Crosscarry would say that all this stuff that I've talked about adds up to a perfect storm for medical error. This is all quite depressing, isn't it? We had the uplifting talks first. I should have gone first, really, shouldn't I? And then talking about this, I mean, there's no point talking about this unless there is something that we can do. And there's a problem because you can't turn off system one. You can't stop that intuition. So what can we do? This is called the Muller-Lyer illusion. Which line's longer, which one's shorter? The bottom one, even if you know what this illusion is about, when you look at it, the bottom line looks shorter than the top line. But if you measure them out, the horizontal lines are the same length. So system one is telling you that the bottom line is shorter. But system two, once you've measured it, even if you see this again and it looks shorter, you know that it's not. So that's what we need to find out how to do with the way that we think in the emergency department and in other critical care settings. I keep forgetting that I work in ICU. All these guys. So how can we think better? Metacognition we've talked about. We need to think about how we think. We can use cognitive checkpoints, obvious ones like the AAA and the loin pain patient. But there's other things that we can do. We can use checklists. We can use guidelines, decision-making aids. All of these things help. We can reduce cognitive load, basically using the same sort of things, and also cognitive forcing strategies. We need to turn our experience into expertise, and lots of other guys have talked about different ways of doing that. Things like simulation, visualization. Scott the other day talked about we have to read. And this is important because we need to use evidence. We need to use hard literature to inform our illness scripts so that we know what patients really present with. They don't all read the textbooks. We need to also inform our pretest probabilities so that we know what's likely to be common, because pretest probability is probably the most important thing that determines what the diagnosis is, far more important than all those tests that we order. We need to take a leaf out of Feynman's book and learn about thinking critically. If I press harder, it will work. Are you able to skip to the next slide, please? And we need to optimize our work conditions. So things that we can do is try and make tasks simpler. We can delegate tasks. We can make sure that our rostering works well, that people are adequately supervised. Okay. And most importantly, we need to look after ourselves. We need to learn how to ask for help. We need to keep ourselves well rested. We need to get sleep. We need to feed ourselves. I probably don't do that very well, as you can tell. And I forgot what I was going to say. Let's move on. And finally, I want to say what we need to go and do now after this talk. So I'm having a bit of struggle with the thing. So what we need to do is to think about this stuff, learn more about it, talk about it with our peers, and then find ways of trying to put it into practice. I want you to not be blind to cognitive blindness. Don't be afraid of the psychobabble. A good place to start is to read anything by Pat Crosscarry. In this book, Patient Safety in Emergency Medicine, I got it and I just read it cover to cover in like a day. It was just fantastic. And another great place to start that's already been mentioned is Daniel Kahneman's book, Thinking Fast and Slow. He won the Nobel Prize basically for weeding out basically what this stuff is, and Pat Crosscarry has really helped transfer it into the emergency medicine and critical care thinking areas. And if we do this, we may just be able to be jackasses a bit less often. So thank you very much.